Welcome back. This is part 5 of the nutrition support series for the Skills Lab. And we left off last time talking about the complications of specialized nutrition support. And most of the complications are related to TPN or parenteral nutrition, but enteral has its fair share as well, and we'll talk about those in just a minute. But one thing that's common to all of them are basically the three types of complications: mechanical, infectious, and metabolic. And all the typical complications will fall within one of those categories. Mechanical are things like when they place the IV line, that central line, or maybe the feeding tube into the nose, wherever. It can end up in a place it's not supposed to be. So it punctures something. It's really a surgical technique and a matter of getting the device in there. So not so much the nutrition product itself, but the route of the tube or the IV line. And infectious complications would be related in a parenteral, for parenteral nutrition, related to the fact that you've got a central line going through the skin, and it's not uncommon for that site to get infected, and they call them bloodstream and central line related bloodstream infections, typically with Staphylococcus aureus, usually MRSA, unfortunately. And with the tube feedings, having the tube go through the nose, if it's in there for a week or two or longer, of course, infectious sinusitis becomes a problem. Metabolic is probably the more common one that we deal with, that we monitor for, and much more familiar with. And one of the big metabolic complications is related to overfeeding. We mentioned this earlier. I think it was in session 1 where we talked about why we want to feed the patient's ideal amount and not under or over, because the overfeeding or giving too many calories, too many nutrients, can lead to things like fatty liver infiltration. That's where the liver stores excessive carbohydrate as fat, converts it to fat, and that impairs the liver's ability to do its hepatic functions. And the process of burning and storing all this excessive carbohydrate leads to excessive carbon dioxide or CO2 production, as well as leading to hyperglycemia, because the pancreas insulin secretion can't keep up with the amount of carbohydrate that's coming into the body. A few more specific things. The hepatic steatosis is the fatty liver infiltration that we talked about. It's just another term for that. Hypercapnia is the excessive production of CO2. We talked about hyperglycemia. Refeeding syndrome is another complication that's it's more rare to see, but you do have to be on the lookout for it. And that's where you feed somebody too much too soon, and they have electrolyte shifts and abnormalities, particularly very low potassiums, magnesium, and phosphorus. So this is something you would see with somebody who's in a semi-starvation state, or somebody who hasn't eaten in a long time, they're already malnourished, and then you give them too much nutrition too fast, too early. Again, the whole start low, go slow idea comes into play here. And we talked about line infections or catheter-related sepsis. That's where the Staph aureus gets into the site of the central line. Aspiration pneumonia is related to enteral nutrition, and that's where the tube feedings that are supposed to be in the stomach make their way back up the esophagus and to the patient's throat, or find their way then down the trachea and into the lungs, which can cause a pneumonia, especially if it picks up anaerobic or gram-negative bacteria from the patient's mouth along the way. And I talked about infectious sinusitis that can be seen when feeding tubes are left going through the nose for 1 to 2 weeks or longer. So to prevent complications, monitoring is a very important component. And we look at things like serum chemistries, especially the magnesium, phosphorus, potassium. For fats, we talked about this earlier, we monitor the serum triglycerides. If they get too high, then we have to back off or even discontinue the intravenous fat emulsion or lipids that we're providing. And 400 milligrams per deciliter is a good cutoff number. If the patient's level is exceeding that, they probably shouldn't be receiving any exogenous triglycerides, which are, again, our lipids and fat emulsions. Complete blood count, that's the white blood cells, neutrophils. That'll give us an idea if they're experiencing an infectious complication. And visceral protein markers like albumin, prealbumin, these are kind of to help us know if our monitoring, if the therapy we're providing is effective, and that's more so with long-term TPN. Short-term, 1 to 2 weeks of TPN, the albumins, prealbumins, and other markers really don't tell you much about their nutritional status, but you want these things to increase over time. So very important for somebody who's on long-term TPN, like 3 months or longer, or home TPN for life especially. And gastric residuals, we're going to talk about more in a minute, but that's also related to the tube feedings. And that's the amount of tube feeding that's left in the stomach. The nurse actually checks it, and you want there to be very minimal residual. In other words, as you're putting food into the stomach, that it's going on through into the duodenum and so forth, and not staying in the stomach. That could be an indicator of tube feeding intolerance. A few more things about monitoring. We check the GI tract's functionality by listening for bowel sounds. We look for the patient have flatus and bowel movements. If their GI tract's not working, we probably don't need to be using it or even trying to use it. Then the amount of PO intake. If they're able to eat by mouth, we monitor that closely too. And as that amount increases, we can start decreasing the amount of either tube feeds or TPN that we're providing. And the tolerance of specialized nutrition support, of course, these kind of plays into all these things that we're talking about. That can also include things like fluid status, if they become fluid overloaded, if the electrolyte shifts and changes. And then overall, the patient's progress. How are they doing? Are their wounds healing? Are they feeling better? Are they able to get up and move around? Because if nutrition support is supposed to support all these other bodily physiologic functions and processes, then you kind of look at the patient as a whole and kind of assess, are they getting better or not? And if not, does that mean that you could have underestimated their nutritional needs? Perhaps you should be feeding them a little more aggressively. And this slide is put in the presentation just to remind me to talk about a very important problem or concern that we have with compounding of TPN, so probably more a mechanical type of complication. And obviously this picture is a snowstorm, and it's the snow that sometimes we use somewhat jokingly to talk about precipitation in a TPN. And so if you've ever seen precipitation in IV fluid, it kind of somewhat reminds you of a snow globe or a snowstorm. So what I'm really getting at here is the problem with calcium phosphate precipitation within a TPN. It happens usually during the compounding process, and the problem is if it gets from the TPN bag into the patient, very bad things can happen, including death and severe suffering. And in 1994, there was an FDA safety alert addressing this very thing. Case reports of death and respiratory distress, and it was related to the calcium phosphate coming from the TPN. It had precipitated, and of course it's not supposed to precipitate, it's supposed to stay in solution, and when it forms the precipitate, it can end up in the lungs, muscle tissue, the kidney, the heart as well, but it tends to be the lung destination where it ends up being a pulmonary embolus, and again can cause death. So it's dibasic calcium phosphate is the technical term for the little solid that's precipitating out. And things that affect solubility of calcium phosphate are pH, concentration, temperature, and time. So with pH, the more acidic or the lower the pH of TPN is, the better solubility there is for calcium phosphate. In other words, it'll stay in solution. If you alkalinize or raise the pH of a TPN solution, either on purpose or inadvertently, then calcium phosphate will precipitate out, form the solid much more rapidly. And the concentrations of calcium and phosphate themselves that you're adding to a TPN bag, of course, play an important role. Think of the law of mass action. If you have calcium plus phosphate ions on one side, then the arrows, and you go to the calcium phosphate solid or precipitate on the other side of the reaction or equation. The higher the concentrations of your calcium and phosphate to begin with will drive that equation to the right, where you end up with the precipitation of the solid. Temperature also, that's why we refrigerate, keep the TPNs cool until we get them to the patient. The warmer it is, or the higher the temperature, calcium phosphate will precipitate out. in time, the longer that these things sit in solution together, the chances of precipitation will increase. And so that's why we give TPNs usually a 24 to 36-hour expiration time. Beyond then, it's very likely that it'll start precipitating out regardless of the temperature, the concentration, or the pH. So one safeguard we have is we put a filter in place between the TPN bag and the patient's arm or chest wall or wherever the TPN is infusing into. So as you can see here, this is the filter. So solution is coming down here from the TPN bag and through this tubing. It has to go through this filter first, and then it will find its way into the patient. So if there are things larger than 0.2 microns, like for example a typical crystal of calcium phosphate and other things, some fungus, some bacteria, it'll get caught in the filter and not make it into the patient. So it's a good safety device to have in place for all TPN bags. Another thing we look out for with the 3-in-1 or total nutrient admixture TPNs, and this is where they have the dextrose, protein, and lipids all in one bag, is the fact that when you add things to that lipid emulsion, for example, the electrolytes, the protein, the dextrose, different chemical factors can contribute to cracking or breaking of the emulsion. In case you want it to be a nice homogeneous emulsion, but if you do something that causes the oil and water to separate, you have a cracked or broken emulsion. And this is an example. So this is what you would see as you're inspecting your final TPN bag before you send it up to the floor for the nurse to administer, before you dispense it. If you see this line of kind of a brownish to dark brown separated phase, that's a broken admixture, cracked emulsion. And you don't want to send that to the patient because that could result in an oil embolus, which is also very dangerous to the patient. And this is just a close-up of what you would see, cracked emulsion. You want it to be that that same kind of milky white color. Okay, so switching gears a little bit, now we're going to talk about enteral nutrition, which is the other type of specialized nutrition support in addition to parenteral nutrition. So tube feeds and enteral nutrition can be a little daunting. There's so many products and it seems like there's so much to choose from, so much to think about. It's hard to pick a product. So which product should I use? How do I decide? As you can see here, these are a lot of examples of different things that come in a can that you would drink, something that comes in a tube feed where you'd have to administer it through a nasoenteric feeding tube, so on and so forth. So I like to break this selection down into really starting off by breaking all the formulas down into two different types, either standard formulas or disease-specific formulas. So standard formulas are things like your Boost, Ensure, basically a steak and potatoes dinner liquefied or blenderized into something you would drink, and it's got all your protein, carbohydrate, fats, vitamins, minerals, electrolytes, all the stuff you would need. And we could all live off of this for many years, if not for the rest of our lives, and a lot of patients actually end up utilizing these type of products for the rest of their lives, and they live happy and productive lives. They just can't eat regular food like we do. So that's a standard formula, pretty run-of-the-mill kind of thing. Then you've got disease-specific formulas, and there's a lot of these out there. There's a big market for this. Are they really significantly better than standard formulas for these particular diseases? That's debatable. Not a whole lot of evidence-based medicine to support it, but I just want to introduce you to some of these. So there's things for glucose intolerance, targeted at people with diabetes or having glycemic dysregulation, patients with renal dysfunction where they have fewer electrolytes and usually volume concentrated so as not to cause fluid overload. Other fluid restricted formulas as well, just a low volume. And then there's other formulas that are specifically directed at patients with malabsorption. And these are things that are, instead of having a peptide chain as the protein, which is what we get from meat and other sources, it's more broken down into peptides and dipeptides, or free amino acids even. And so we'll continue talking about enteral nutrition in the next session.